to the Friday Five here on the Agent Survival Guide podcast. It is our weekly list of 5 things you should know about. I'm your host, Sarah Ruppel, and this week our show is powered by pollen and quite a bit of allergy medicine, so hold on tight. No telling where this one might go. But in all seriousness, we do have a lot to cover today because quite a bit has been happening since our last regular Friday 5 episode. Let's start out at number 5. Dr. Oz has been confirmed and sworn in, so he is now officially administrator of the Centers for Medicare and Medicaid Services. And in the time frame since that happened, there has been a flurry of activity from CMS, including the 2026 MA and Part D rate announcement. We featured snippets from that announcement in our episode prior to last week's break, so just in case you missed it, we will be linking to that in the episode notes. We'll also be linking to Dr. Oz's mission statement for CMS that was released on April 10th and outlines some of the ways his team plans to, quote-unquote, make America healthy again. Another recent regulation I'd like to talk about, the final 2026 Part D redesign program instructions, coming in at number 4. Quick background on this regulation. The Inflation Reduction Act restructured Part D cost liability and changes began being phased in back in 2023. CMS publishes program instructions to outline how coverage changes for all those involved, from drug manufacturers and insurance carriers to the government and Part D enrollees. Let's get into the Part D coverage phases and costs for plan year 2026. We'll start with the deductible phase, where an enrollee is responsible for 100% of the Part D deductible. That amount has been set at $615 for coverage year 2026, up $25 from 2025 amounts. When the $615 deductible is met, the Part D enrollee moves on into the initial coverage phase. In the initial coverage phase, costs are broken out 2 ways, depending on a drug's qualifications for the manufacturer discount program. If a drug is covered by an enrollee's Part D plan, it does not qualify for the manufacturer discount program, so it is considered a non-applicable drug. On the other hand, if a drug is not covered by an enrollee's Part D plan, it qualifies for the manufacturer discount program. We refer to these drugs as applicable drugs. While the enrollee is in the initial coverage phase, they pay 25% coinsurance of covered Part D drugs. The issuer of the plan, the insurance carrier, pays 75% of the cost of drugs that are covered by Part D. So a 25-75 split on cost responsibility between the beneficiary and the carrier, respectively, for non-applicable drugs. When it comes to applicable drugs, or drugs that do qualify for the manufacturer discount program, the insurance carrier, or the issuer of the plan, pays for 65% of the cost. The beneficiary pays 25% of the cost, and then the manufacturer pays for 10% of the cost. The enrollee exits the initial coverage phase when they hit their out-of-pocket threshold, which in 2026 is set at $2,100. The third and final phase of Part D coverage is catastrophic coverage. In this phase, the enrollee does not pay for prescription drugs, whether or not they are covered by the Part D plan. But there is an important difference on how costs are handled on applicable versus non-applicable drugs. For non-applicable drugs that are covered by the Part D plan, the insurance carrier pays 60% of costs. CMS pays the remaining 40% of costs. For applicable drugs, the drugs that are not covered by the Part D plan, the insurance carrier still pays 60% of costs. CMS pays a reduced 20% share of the applicable drug cost, and the drug manufacturer steps in to pay the remaining 20%. So to recap, in catastrophic coverage, your client pays nothing. The insurance plan always pays 60%. And then depending on whether or not the drug qualifies for the manufacturer discount program, the cost is either paid by CMS in full or split between CMS and the drug manufacturer. Moving on to number 3 on our list. You might be wondering how drug price negotiations are going to affect cost distribution in Medicare Part D. And rightly so, because the particulars of that program do switch up the Part D cost structure a little bit. And before we get into this, I have to give a huge shout out to our marketing team editor and lead copywriter, Roxanne Anderson. We dug through the weeds of the Federal Register on this one to make sure we could explain it in an easy to understand manner. And without her, I'm not sure I would have gotten there. So huge shout out to Rox. Now let's get weeding. The 2026 plan year marks the implementation of negotiated drug prices for Part D beneficiaries. We've got our list of 10 drugs that qualify for the selected drug subsidy. Because these drugs qualify for the selected drug subsidy, they do not qualify for the manufacturer's discount program. Also important to remember, the subsidy is only available while an eligible beneficiary is in their initial coverage phase. That means that the cost structure for drugs in the subsidy program follows the cost structure of non-applicable drugs, drugs that are covered by Part D and not part of the manufacturer drug program, while the beneficiary is in the deductible and catastrophic coverage phases. Cost structure differs, again, in the initial coverage phase. In the initial coverage phase of a drug in the subsidy program, a Part D beneficiary will still pay 25% of the cost. That amount does not change. The insurance carrier portion of the cost is what changes. They'll be responsible for 65% of the cost of a drug in the subsidy program, with CMS paying the remaining 10% subsidy. Moving on to another CMS regulation. I mentioned 2 weeks ago that there wasn't much in the 2026 MA and Part D final rule that had changed. But that doesn't mean that nothing changed. In the final rule, CMS announced that they were in fact not finalizing a few proposals and provisions outlined in the proposed rule. So coming in at number 2, the 3 provisions that were specifically named by CMS. The first, enhancing health equity analyses. Annual health equity analysis of utilization management policies, procedures. The final rule mentions that this provision is under review. It's one that falls under an executive order calling for consistency and decreasing undue burden. The second, ensuring equitable access to Medicare Advantage services, guardrails for artificial intelligence. This provision from the proposed rule was a call to ensure use of any artificial intelligence in the Medicare Advantage space. Algorithms included, quote, promote equitable access to care and person-centered care for all enrollees, end quote. CMS deferred adopting this provision in the 2026 final rule, but stated that the organization, quote, does want to acknowledge the broad interest in regulation of AI and will continue to consider the extent to which it may be appropriate to engage in future rulemaking in this area, end quote. And then the third, Part D coverage of anti-obesity medications, or AOMs, and application to the Medicaid program. Little surprise here, this has been a contentious area for insurance carriers across the healthcare space, not just in Medicare or Medicaid. Part D drugs have always been excluded from coverage by Part D sponsors when they are used for weight loss purposes. If it's used for weight loss, that use is not included in the actual definition of a quote-unquote covered Part D drug. And while GLP-1 drugs are prescribed and used to treat diabetes, it's no secret that the bulk of their popularity comes from the off-label use as a weight loss drug. In late November 2024, the Assistant Secretary for Planning and Evaluation published an issue brief outlining the cost of Medicare and Medicaid coverage of AOMs. CMS projections came in at a $14.8 billion increase over the next 10 years for the Medicaid program. In Medicare, it was estimated that adding AOM coverage would cost about $24.8 billion over the same time frame. That would have amounted to almost $40 billion in spending over the next 10 years. Now, let's move on to number 1, the things that CMS is not implementing in the final rule that they didn't mention in the fact sheet, but are very important to agents. I think one of the most interesting things about digging into CMS legislation is that they typically tend to focus on the consumer side of things, rather than any of the other participants in the healthcare industry. So that means there are usually some takeaways for agents that are either glossed over or not mentioned at all in the summaries and fact sheets. There are 2 big ones that I will mention here today, but that is certainly not everything included in the final rule. A big topic that has been talked about left, right, and center when it comes to Medicare Advantage and Part D, prior authorization. CMS was split on this one. They finalized the requirements around inpatient admissions, but as I mentioned earlier, they're not finalizing the use of AI in anything MA related, prior authorization included. And then the second thing, a big one for agents and us here on the educational side of things, marketing reforms that would have redefined the term marketing and required a lot more materials be submitted to CMS for approval before publication. I think I mentioned this in our coverage of the proposed rule, and if not, I definitely want to mention it here today. I know that CMS has good intentions with these rules. I understand what they're trying to do. None of us want the bad actors who are misrepresenting plans or benefits to prey on unsuspecting beneficiaries. But this particular provision would have been a huge lift for CMS to take on. There's a section in the final rule dedicated to reviewing how many more materials would have passed through CMS, the time it would have taken to review them, the money spent, the amount of employees needed to do that. And given the current administration's tone on government efficiency, it makes sense that they didn't simply push this through as written. Now, double-checking beneficiary qualification for low-income subsidies or extra help. What happens when you switch between original Medicare and Medicare Advantage? The potential need for underwriting into a MedSup plan. Most agents worth their salt are doing those checks anyway without adding them to the process as a CMS rule. Most agents are asking those questions, and those answers are going to lead you to plan selections that are just a better fit for that client. The more information you have, the better. as I mentioned, this is not everything that was included in the final rule. These are just some of the more high-level takeaways that would have had a big impact had they gone through. But thankfully, they either will not be finalized or will not be finalized as written. To stay as updated as possible on CMS legislation, highly recommend following along with our show. You can do that wherever you're listening right now. I also recommend following along with our blog. We will have the link to do that in our notes, along with more resources from both our podcast, Ritter's blog, and more. You can find all of that in the episode notes. And that does it for this week's episode. I hope you have a great weekend. Stay healthy and stay safe out there, and we will see you next week. The Agent Survival Guide podcast is a production of Ritter Insurance Marketing, an integrity company. This episode was written and produced by me, Sarah Ruppel. Script editing and fact check by Tina Lamoureux. Podcast design by Urban Rivera. Follow along with our show wherever you like to listen.